Thank you so much, and good evening, Mr. Chairman, and ladies and gentlemen. And I would say that the iliac aneurysm, especially involving the common iliacs and the internal origins, have been always been a challenge for the vascular surgeons. Either it's very easy to occlude the internal iliac with a uni-iliac device or the arms extending into the external iliac. But if we have to keep the perfusion on for the internal iliac, either you have to reimplant during a surgery, or you have to take care that you don't jail the internal iliacs, because if somebody has seen complications arising from internal iliac occlusions, it's very, very scary. So I just present a case, and we are very happy that the advances in the hardware, now the hardwares are available for at least some percentage of patients where they have a suitable anatomy. It's not something which is very difficult to do, but it's just a matter of the suitable anatomy, then only you can offer this device to these patients. So this was a 59-year-old male patient. He had presented with complaint of pain, lower abdomen, and on examination he had a pulsatile mass. The duplex showed he has an additional dilatation of the iliacs, and this was his CT angio. So here you can see both the common iliacs are aneurysmal, and to our good luck and for patient's luck, we have a suitable landing zone on either side. There were good neck on the common iliac side as well as on the external. The origins of the internal were not aneurysmal. They had a suitable length also internal, so that we could put a stent graft in the internal. Straight away I'll come to the angiogram. So what we usually do is that we place two stiff guide wires on either side and take angio from the brachial axis, so that we get exact measurements, and once we have overcome the tortuosity, we see how these exact measurements are going to be, because it's very important how to place the graft properly, because if we don't place the graft properly, sometimes through the branched device, it's very difficult to cannulate the internal iliac. So here you can see that we had taken, and in this patient we thought that first we'll go ahead and do the cannulation for the right side, and this here you can see the device being placed. So here you can see there are three markers. So these are the markers which are there for the lower one is for the branch where it opens, and there is a pre-fed catheter which a pre-fed catheter is there, which you can pass a wire over across to the other side, which has to be snared, and then eventually you come from the other side with a sheath, and then you go through the branch into the internal and cannulate it, and then you can place your stent graft, either a Viaban or a Advanta, whatever you like, and whatever the anatomy is suitable for, you can do that. And unfortunately, in this patient, we could easily manage. The snaring was not difficult, because this is a good snare which is provided with the IBD, and it was easily snared, the wire on the opposite side. But the problem was the bifurcation was quite acute, and passing a 20 French sheath was a little problem. With a stiff wire also, we changed over stiff wire, tried all the maneuvers. Then we had to abandon, and we thought that since we already have access from the brachial, so there was no way that we could cross a 20 French sheath from the contralateral side. So it was preferred that we'll come from the brachial and then complete the procedure. Only issue is that all the Indian patients, the brachial size is not very good. But being surgeons, it was not difficult. Rather than doing a percutaneous access for a 8 French ancel sheath, where the outer diameter is more than 8 French, we preferred, because the brachial size was not very big, so we thought we'll do an open access so that we don't land up in any brachial sort of a thrombosis. So we converted into an open access for the brachial, and then eventually, gradually we started opening the device. Here you can see the device being opened. Now the important thing is, when you open this device, you see here you can see the branch opening. So important thing is that this branch has to be at least a centimeter away from the internal iliac, minimum, so that you can easily cannulate. If it's too close or if it's too far, then sometimes it becomes a little difficult to cannulate. So here, if you can see, the branch is just 1 centimeter away, and here you can see under a road map, you can see, if you can see carefully, there's a wire which is being advanced, cannulated the internal iliac, and this was through a catheter coming from the brachial axis. And then once you advance the sheet into the internal iliac, assess your internal iliac, and then this was the Advanta which was placed into the internal iliac. And once you balloon dilate, you have your seal, a good seal proximally, distally, as well as through the internal iliac. And this is the completion angiogram for the right side. So you see there is no endoleak. You have nicely created the internal iliac. All the branches are very well preserved. So now eventually we had to come for the other side. So other side we didn't even try to snare. You can see the pigtail which was there, the pre-fed catheter. We had just pulled out the catheter before we try to cross a wire and do a cannulation from the opposite side. We had pre-planned that we will go ahead and come from the brachial route only. So you can see the only issue was this side, it was a large aneurysm. We always had our reservations that sometimes it becomes very difficult in a blind sac to cannulate coming out of the branch and cannulating the internal. But again, with proper, I would say, angulation of the C-arm and identifying where exactly it is, then you can orient yourself nicely and then open the branch close to the ostia of the internal. But you can see here, when we took the shot, you can see that there is a large aneurysm, and it was a little difficult to cannulate the internal, but with a proper angulation, and believe me, it didn't take much time, and we could pass the catheter into the internal, and once your catheter is in, the most of the job is done. So here again the sheath and once Advanta on the other side. So you can, then the rest of the device was open. Only in this case, when we were opening the rest of the device, we kept the balloon inflated because this was in an aneurysm. You don't want, unless until you have a proper seal, because these stents, they don't have a barb. So in an aneurysm where if you don't have you are a little apprehensive that it should not move or it should not fall into the aneurysm. So till you have opened the whole device, we kept the balloon inflated so that there is some sort of a tug or a resistance maintained on the device. And this is the final completion angiogram for the same patient. So easily we could maintain the perfusion of both the internals, no endo leak, get away with. But I think I would say everything is because of the proper anatomy, suitable anatomy. That's why the case was very easily performed. But I think as more and more cases we do it, I think more and more challenging anatomy will be able to do. Only thing is that we have to have at least minimum 16 millimeters of diameter for the branch device to open in the aneurysm. And we should have at least a minimum of say 1.5 to 2 centimeter or one stent seal proximally to avoid. And IBD we have done IBD before also in conjunction with the aortic aneurysm. That's not difficult, but I think what we were told was this was the first bilateral IBD performed in our country. Thank you very much.
Thank you, Dr. Grover. Do we have questions from the panel, please?
It was a very nice, challenging case and an excellent result. Just two questions. One is, did you have coaxial or views from your CT of the iliac and the femorals?
Sorry, you said we do have?
Did you have cross-sectional views from the CT?
Yeah, we had cross-sectional views also, and luckily we are privileged to have a Dyna CT within the theater, so we can do a rotational angiogram also and have a proper X.
Right, because sometimes that can help you, especially for these large bore sheets. It may look, very appetizing with the angiogram, but on cross-sectional, views, you can see calcification that would hinder you or make getting a large sheath.
I think it was more of acute angulation rather than calcification in this patient because we didn't see much calcification around the aortic bifurcation. It was more of the acute angulation.
And the second question, just out of curiosity, you think the aneurysmal disease was causing this lady's symptoms? You said she had lower abdominal pain.
I think so, because they were quite large aneurysm, and this patient, because he was not a very, very obese, as you had seen from the angiogram, so I'm quite confident that probably the symptoms were because of the aneurysm. And anyway, such large aneurysm, you can't just not treat them, because if they're not symptomatic also. I don't think so anybody will like to leave such large iliac aneurysms.
Did the symptoms go away after the procedure?
It's because all these patients are outstation patients. So if they're not back to us, so we believe that no news is good news. So once they come for a follow-up after 6 months, then we'll know. I'm sure if he had some symptoms, he'll definitely get back to us.
And just as a question, suppose we didn't have this device, was it okay to put two parallel stent grafts, not like a chimney, but one going into the internal iliac, one going into the external iliac?
Like a sandwich technique? Yeah, definitely. The sandwich technique is well described. We have done for a few cases, but only thing is, if you have a suitable anatomy, then why not to do with a device which is meant for these sort of anatomies? Because you can always do a sandwich where you feel that the diameter is not significant, large enough to open the branch. Then you can definitely do a sandwich.
I was thinking about Dr. Henry. Would a multi-layer work here?
Yes, I think so, because now we have a new device, a bifurcated device, so you can implant the stent in the aorta and both branches, so it's perfect for this kind of bilateral aneurysm. Sure.
Dr.
With a
Rabi,
bifurcated device.
I think Dr. Rabio Ruffino from Italy he was responsible for the Italian registry on the MFM, and they had, I think, if my memory serves me correctly, 16 iliac artery aneurysms that they treated to either hypogastric aneurysms or iliac aneurysms that extended down to the iliac bifurcation, treated with the MFM very successfully, all with progressive aneurysm shrinkage and good exclusion, patent hypogastric vessels.
Thank you very much, Dr.
Thank
Grover.
you. Thank you so much.